Okay, let me welcome you all for the CMASL webinar series. This is the third one, and the topic is Safe Hospital Initiative. We have got 4 main speakers. Dr. HDB Herat is a registered SLMC. Then Dr. Prabhat Amarasinghe is a Deputy Director, Medical Research Institute. Then Dr. HLS Chaturika, she's a Senior Registrar in Medical Administration, Ministry of Health. Then Dr. Samindi Samarapon, she's a Deputy Director General, Education, Training, Research and Research Unit of the Ministry of Health. Unfortunately, Dr. Samarapon is not available for the today's meeting, and I'm going to do her presentation as the moderator. So, without taking that much of time, but I thought we'll go ahead with the particular presenters. And before that, I think this is transmitted at the YouTube. So all the participants are from the YouTube, and they can type their questions at the comment box, so we can just go through at the Q&A session. We can't hear you. I think
I can now. I can now,
yeah,
because there was some connection problem, but now only I can hear you, Suranga. So
yes.
So I can start my presentation now. I think the video is also now working. I will start with the presentation. I will be, can you hear me? I believe that you all can hear me.
Yes, of course, we can hear you.
Yes, okay. Then, first of all, I need to thank the organization of this webinar for having invited me for this presentation, to make this presentation. Thank you very much, Suranga, Sanita, and Prabhat, and everyone. We know that, sorry, the hospitals are very important part of our community. And we know that they are providing services to the community that is vital for the survival of the community. So therefore, we have to take hospitals as an important part of the whatever the community that we are living. And why hospitals are important? One is the hospitals are providing very important services to the community, and it houses a range of highly skilled staff that are not easily replaceable. Just like taking out unskilled laborers from a factory and putting new people in, we cannot do the same with the hospitals. And therefore, it's another aspect is that the hospital is housed with or accommodated with a highly skilled set of staff of different categories, which are not easily replaceable. And also inside the hospitals, there are extremely expensive equipment there, and very hard to purchase. Some of the equipment, even in a smallest hospital in the country, may be having millions of rupees worth equipment in a smallest hospital. And also, it's required to play an important role in disasters and emergencies. When there is a disaster, we know that schools are closed. All other the organizations or institutions may be closed, but hospitals cannot be closed. So those are the most important aspects that we have to take into consideration when it comes to the managing of hospitals within the framework or within in a scenario of a disaster. And hospitals in disasters, the most important thing is they can get affected again, sorry, due to disaster, and the hospital itself can get affected, staff can get affected, the functions can be disrupted, and therefore one important point that need to be kept in mind our mind is that it's a very vulnerable place as far as disasters are concerned, and have a it has to cater the increased demand for services after a disaster, because after a disaster you get several types of, firstly, the injuries, deaths, and then probably after handling all these injuries and deaths, there will be internally displaced people for whom we need to provide specific health services. So to carry out all these things, the hospital needs some kind of a surge capacity built inside the hospital to face a disaster. So I'm not going to details of the hospital safety part, but to make it complete, I just want to mention that hospital safety is divided and can be divided into three major aspects. That is the structural safety, the non-structural safety, and the functional safety. That is, you know that in a disaster, you will get, now these are the some of the pictures that I gathered managed to gather from the tsunami, Mahamodar Hospital. You can see what the damage it has caused to the hospital. And this is how the equipments in the hospital were damaged, and you know how much cost an incubator, and not only one incubator, probably several large number of incubators may have been damaged during that incident. And the ambulances, again, hard to replace, hard to buy, and these ambulances and similar equipment could be damaged. Buildings are themselves could be damaged like this, and therefore it is important to think about, firstly, the structural safety, that is the building itself. Again, I'm not going into details because most of you all probably are aware that structure of the building, firstly the location, that is if it is closer to a sea coast, you know what are the vulnerabilities as far as that hospital is concerned. And if it is located in a high mountain, what would be the vulnerabilities? And if it is located in a lowland, near the coast, tsunami, cyclones, high tides, and all other things could damage the hospital. High rise or in a mountain or somewhere, landslides are the most important problem that they can face. Low line, the inundation with floods and other things. So location, and then the simple design and the structure of the hospitals, the strength of the columns and beams, all these are engineering facts, and the walls and other things that are keeping the hospital basement in place. All these things are structural safety. And also there are several other non-structural safety, like ceilings, windows, the equipment, and the electrical wiring, plumbing, and you know that, and the safety and security systems. All these things are not structural parts, but non-structural, but very important aspect. Then the other important aspect is the functional safety. That is the hospital's functions, the site and the accessibility. That is how to reach the hospital, and within the hospital and near the hospital, from gate to the wherever you want, to the mortuary, to the laboratory, and so if the accessibility is disrupted, then there will be problems. And we know that equipment, supplies, and all these things functionally, we need to keep ready to face a disasters, emergency plans, operation procedures. All these things are not structures, not non-structures so-called, but a system that is within the hospital. These are, if all these things are uh, in they are in place, we can say that the hospital integrity is achieved to a certain extent. So the structural integrity, that is, the structural parts are in place, non-structural integrity, that is, non-structural parts are in place, and functional integrity, that is, functional parts are in place. So these all three aspects are being considered not only in Sri Lanka but also internationally. And the WHO has initiated this so-called Safe Hospitals initiatives to make hospitals resilient to disasters by improving the structural, non-structural, and functional integrity, and improving the safety of the hospital. So this concept is regarded as the Safe Hospital Initiative, and most probably most of you all are aware, and it is available in the literature, online literature, WHO and everywhere. The details are there. And Sri Lanka also has adopted this Safe Hospital initiative in about decades ago, and from time to time we have improved the structural safety, non-structural safety, and the functional safety of hospitals by doing many initiatives, and that includes the probably structural. One good example of refitting the structural integrity is the Nigambu Hospital. Probably most of you all may be aware that there was an issue of structural safety issue of the multi-storied building in the Nigambu Hospital, and to my knowledge, and it was fixed, and probably after my retirement, I did not double check there, but I think that part is now completed. Non-structural part, yes, we know that initially we had our accident service in the so-called former Victoria Eye Hospital near the Vision Care at the National Hospital near Ward Place, and it was not structurally also good for an accident service, but non-structurally also the things were not in a good place to handle an accident service. So it was later shifted to the new place where now the accident service is there. And the functional part, we know that National Hospital itself and all other major hospitals are having their functions, even they are able to withstand those activities to be carried out in a resource constrained setup, and therefore those activities are being initiated. And we know that with this the help of our disaster management postgraduate diploma trainees, we have conducted hospital drills in almost all hospitals in every 5 years or so. And we know that all these people that are given in these slides are part of this hospital management or safe hospital process. And as far as the medical administrator is concerned, I think this is my last slide. The most important thing is there are two aspects. One is the preparedness part, other one is the response part. The most important part that need to be carried out throughout the year is the preparedness, where as an administrator, you need to ensure, you need not to do yourself, but you need to ensure that risk assessment is continuously done and updated, so that when we are aware what are the risks posed by the hospital. And the capacity assessment, again, it's not one and one-stop activity, but it has to be carried out throughout the year to ensure that capacity of the hospital is updated. And we know that most of the time, 100% full-fledged capacity is not there. There are gaps, and continuous activities should be carried out to build that gap, that is to build the capacity. So preparedness and response planning, infrastructure development, human resource development, all these things need to be carried out, and at least periodically, once a year. In WHO terms, it should be twice a year or once in 6 months, but at least once in 2-3 years. If we can evaluate your capacity by doing a drill, that will be the important thing. In case of a disaster itself, the medical administrator should be able to lead the entire process and facilitate the process by giving the leadership in giving medical care, medical legal functions, response coordination, logistics management, and rarely, but not rarely, but very carefully, the research, because that's another important thing in a disaster. Hospital related, after a disaster, there can be unethical research that maybe people might attempt to carry out. So therefore, we have to be very careful, and we should we should be on the look for any kind of unwanted happenings related to research. So within the 10 minutes given to me, I believe that I have tried to summarize what is Safe Hospital Initiative and the other things. So thank you very much once again. If there is any questions, I don't know whether it is this time or at the end of the program, we are going to discuss. Thank you once again, and I conclude my presentation.
Thank you, Dr. Herat. Thank you for the presentation. I think it's really you have really time-bound presentation. So yes, so I need to really inform you all the speakers. I think the Q&A session will be performed after the all 4 presentations. So if someone is having any question, they can really type or at the comment section of the YouTube. So if anyone is connected to these presentations, this webinar via the YouTube, you can really type your question so we can take it up at the Q&A session. So I'm going to present Dr. Samini Samarakon's presentation since she's away at the moment. So can you see that it's broadcasting? Yes, of course. Thank you very much. So I'm Dr. Surangam Dalomul, Director Laboratory Service and the Vice President of College of Medical Administrators of Sri Lanka. I just glanced through Dr. Samini Samarakon's presentation. I think it's really, she has explained everything in a nutshell. And she has given a lot of concepts and even some of the tools which can be used for the assess the Safe Hospital Initiative. And same time, there are some useful definitions as well. So let me start the presentation. So the first question, what is a safe hospital? It's a health facility whose services remain accessible and functioning at the maximum capacity, and with the same infrastructure before, during, and after the impact of the emergencies and disaster. That is the WHO definition in 2015. So it's a really word that's accessible and functioning at the maximum capacity. All right. Just hang on. I think there's a little bit of technical issue, so bit of a technical issue. Yes. slides are not moving. Again, we are going to try it out. Yeah. I think we need to do. Is it moving? We'll try it out from this. Let me handle it. I think we need to accept all those things. It's yeah. So we can do in a different way. Yes. So may I? Yes, this is the way I think we need to do. We can't go ahead with the full screen. So anyway, I think everyone can see this one. So I have really explained what is a safe hospital. So it's the WHO definition is here. So this is the background. So I think WHO has pioneered this particular initiative 25 years ago, and 25 countries reported to have used safe hospital activities. And there's something called Safe Hospital Index. It has been used to assess over 3,500 health facilities. So there are some of the concepts of safe hospital to smart or green hospital. Those are some concept and nomenclature came recently. And the goal is the safe hospital continues to protect lives and health of people from emergencies and disasters. In terms of Sri Lankan experience, I think, as Dr. Herat mentioned, it's a post-tsunami in 2025 action to rebuild hospitals and clinic centers in alternate lands not affected by tsunami. And same time in year 2015 is specifically from October 5th to 19, 2015, a project uh, titled as Sri Lanka Safe Hospital Initiative Assessment and Strategic Plan initiated by Minister of Health. And same time, Department of Civil Engineering, University of Moratuwa, all with the support of Disaster Unit Minister of Health conduct pilot studies as well. This was done in a phased manner. So that is Sri Lankan experience. That's just after the tsunami, it's post-tsunami phase up to now. So the next slide is why should safe hospital be a priority? So there are three main domains: the health issues, social issues, and economic issues. In terms of health issues, it's disaster results to increase demand, uh, and we need to resume routine healthcare service as quick as possible. And we need to really work on the direct and long-term effect of the healthcare interruptions are hard to quantify. And there are a lot of social issues, as mentioned here, and economic issues. That is most importantly, hospitals are significant investment up to 70% of Ministry of Health budget. Non-structural losses can be more costly and more difficult to measure than structural losses. That also a good sort of thing the every administrator should understand. So these are the hospitals, these are the main objectives of the Safe Hospital program in Sri Lanka, to develop national policies and legislation on making hospitals safe from disasters. The second one, to protect the lives from the occupants of the hospital or health facility. That also really important. We need to safeguard our hospital staff as well as patients. The third one, to protect the economic investment as well as the functioning of the both new facilities and those identified as priorities within the health service network. The lastly, to compile, organize, and monitor the implementation of policies and national and international regulation on safe hospitals. So those are the four main objectives. So this is the overview of the hospital safety index, that's called HSI. There's a technical evaluation tool. This can be used to assess hospital safety and vulnerability, make recommendation on necessary action, and promote low-cost, high-impact measures. It also provides a rapid assessment. There's the second edition released in 2015. As I mentioned earlier, more than 3,500 health facilities evaluated by the end of 2015. So this is the index. It has the structural safety, functional safety, emergency and disaster management, and fire safety. I think the first three was discussed at the presentation of Dr. Herath, and fire safety also included here. And in terms of structural safety, there's six pillars: concrete spelling, concentrate, reinforcement of the structural elements such as the columns, beams, and slabs. And the second one is the tracks. Third one is the foundation. Fourth one is the roof and ceiling. Fifth one is the fungal growth and peeling points. The sixth one is damage from the external factors. There are a lot of explanation you can see from here. So I think my IT specialist trying to make this presentation as a full screen. I think it's we are. I think it's not. Is it working? No. So let me go back. Right. So I think you can see this one. I think. I think this one is not. Dr. Herath, can you? Yeah, I think your screen also sharing. That is the reason, I suppose. Yeah. Yeah. Okay. No. So, uh, okay, I think you can. Is it working? Not yet. No worries. Is it working?
No.
Right. All right. So this is the structural safety. I have already mentioned about the structural safety, and okay, this is an assessment of the structural safety in many hospitals. That one is the base hospital, Mahiyangene. You can see the pictures, and Colombo is base hospital, and the Jesh Nuvareli also. They have really assessed the, especially I can see some cracks and some damages. They have already assessed these things. Those are some pictures. And for the functional safety, it's really architectural and non-structural concern safety, and water supply, power supply, or the waste management. That was a very much important area, as well as the human resources. Then where it's really concentrated on is shortage affected the management of the critical system and the overall functioning of the hospital services. That's the for the human resources and equipment and supply. That's one of the important area where availability and condition and ensuring the proper maintenance. That's for the functional safety. So this is the pictures of assessment of the functional safety in some more hospitals. It's really, I think the pictures are for the logistic supply. Okay. The next slide is for the emergency and disaster safety. We have got 5 areas: emergency committee and coordination. I think Dr. Herat has mentioned, and he has explained about the emergency committee and coordination. Hospital emergency and disaster preparedness and response plan, that also he has already explained. Communication and information management, then training and drills, and resource and facilities. Those are the areas of emergency and disaster safety. Then the fire safety, we have got preparedness and planning, and the fire safety system and equipment, as well as training and drills, and special consideration. That they, in terms of special consideration, we have got high fire risk areas identified in drug stores and temporary structures. So in their study, they have identified that the high risk areas are drug stores and some places like temporary structure as well. So those are the findings of the fire safety as well. So in terms of the way forward, they have what they have suggested to inclusion of the safe hospital assessment in the annual action plans of the all hospital. The secondly, adoption of the safe hospital concept when planning of infrastructure development in hospital. That's much more important for the medical administrators. When they want to plan a hospital, I think we need to incorporate the safe hospital initiative in your building and structural planning as well. The thirdly, the step-by-step improvement of the critical hospital that have been assessed and recommendation made for enhancing the safety and emergency preparedness. That also a much more important thing. So those are the 3 way forwards. So thank you very much for listening to this presentation, and thank you very much for Dr. Saminthi for making this presentation. So as I mentioned earlier, the Q&A session will be performed after the rest of the presentation. All right. So the next presenter would be Dr. Prabhat, Deputy Director MRI. It's over to you, Dr. Prabhat. Sorry, sir. Right. Okay, so right. Until Dr. Prabhati's presentation is available, let me give you an update about the YouTube link as well. If someone is available on the YouTube link, you can really send your questions by the through the comment section.
Good afternoon, everybody. After considering the theoretical aspect of the Safe Hospital initiative, I would like to uh, describe to some extent regarding practical application of this tool. Actually, according to previous presentations, we all know now what a safe hospital is. There are three aspects when it comes to a safe hospital we have to consider. First one is the structural integrity as described earlier. That is load-bearing components like columns, posts, pillars, beams, etc. That is something related to structural engineering aspect. Second thing is the non-structural integrity, that is non-load-bearing uh, components like ceilings, windows, equipments, etc. Third one is functional integrity, that is physical design and maintenance of and administration of the hospital. How to do the evaluation of this safe hospital? Uh, Actually, it is conducted by a multidisciplinary team, preferably including engineers, architects, specialists in hospital critical systems, healthcare professionals, specialists in emergency and disaster management, etc. So for this purpose, there's something called Safe Hospital Checklist. Uh, there are 4 modules under this checklist. If I'm going to further describe regarding this checklist is further divided into Module 1, Module 2, Module 3, and Module 4. Under Module 1, we are going to assess the hazard affecting the safety of the hospital and the role of the hospital in emergency and disaster management. Module 2 is about structural safety. Module 3 is about non-structural safety. Module 4 is about emergency and disaster management. So, except Module 1, we are going to consider Module 2, 3, 4 having 151 items rating as low, average, high for each and every item. Then the breakdown is 18 items for the structural aspect, 93 items for the non-structural aspect, 40 items for the functional aspect. Usually, hazards affecting the safety of the hospital and the role of the hospital in emergency and disaster management is considered under Module 1. That is usually something assessed by the disaster management committee of the particular hospital. We are not usually considering Module 1 for the calculation. Module 2 is about structural safety. Under that, there are 2 items, prior events and hazards affecting structural safety and building integrity. Under Module 3, that is about non-structural safety. There are 4 components. That is architectural safety, infrastructural protection, access, and physical security, and critical systems, and equipment and supplies. Under Module 4, that is emergency and disaster management of the hospital as function aspect, there are 7 components. Coordination of emergency and disaster management activities, hospital emergency and disaster management response and recovery planning, communication and information management, human resources, logistics and finance, patient care and supportive services, evacuation, decontamination, and security. So for the purpose of calculation, there are 2 models that can be applied with different weightages. Under model 1, that is for the high disaster prone hospitals, that is high risk of earthquakes and cyclones like disasters. So there are different weightages. For the structural safety, 50% of the index weightage. For the non-structural module, that is 30% of the weightage. Emergency and disaster management is weighted as 20%. Under module 2, all the modules are given equal weightage. That is 33.3% of the index for the all 3 aspects: structural safety, non-structural safety, emergency and disaster management of the hospital function aspect. So we all know Now, the hospital safety index, as described earlier in the presentations, to mention in nutshell, that is a rapid and low-cost diagnostic tool for assessing the probability that a hospital will remain operational in emergencies and disasters. The evaluation yield hospital strength and weaknesses to improve the safety and emergency and disaster management capacity of the hospital. If I further describe regarding this index, that promotes the low-cost, high-impact measures for improving the safety and strengthening of the emergency preparedness of the hospital. So, with that, I have done an evaluation of disaster preparedness in three selected hospitals in the province of Sri Lanka with three approaches. First one is the application of the traffic light color code system for disaster surveillance. Second one is the assessment of the technical staff knowledge, attitude, practices of disaster preparedness and intervention with an intervention. Third one is the gap analysis with the safe hospital checklist. That is the thing I'm going to describe further, just to show about the traffic light system. I have just applied this for the unit-wise hospital preparedness, mentioning these units as the color code, and also in detail assessment for the key components of disaster preparedness, that is communication control and command and control, communication, safety and security, triage, search capacity, continuity of essential services, human resources, diagnosis, logistics and supplies, and post-disaster recovery aspect. So with that, for the gap analysis, the safe hospital checklist was applied for gap analysis according to the values for structural and unstructural and functional components. Safe hospital index was calculated as the value was 0.25 for each hospital. The value was under category B. That is to mention for the elaboration, general recommendation and intervention. This is category B. The value being the range 0 to 1, that is 036 to 065. The short-term intervention is needed, and also hospital is at risk for the disaster situation. So we have to retrofit existing facilities, and we have to consider about these three aspects when it's come to the designing phase of new facilities. If I am going to further show you regarding this checklist, if I'm going to show you further regarding this checklist, this is the checklist. There are 4 modules. Under all aspects of structural and functional, there are a lot of items, 151 items. Yeah. Thank you.
All right. Thank you, Dr. Prabhat. It's really a fascinating presentation. So let me invite Dr. Saneta Chaturika for the next presentation. She is the Senior Registrar in Medical Administration. And she's also going to present on Safe Hospital Initiative. I think it's really, the topic is Safe Hospital and Disaster Nursing, synergetic approach. So we are looking forward to hear about her approach in terms of the disaster nursing. It's over to you, Dr. Chaturika.
Thank you, sir. Good afternoon, everybody. I'm Dr. Chaturika, Senior Registrar in Medical Administration. First, I would like to thank the President, Academic Chair, Office Bearers, and all the members of College of Medical Administrators of Sri Lanka for giving me this opportunity to share the findings of my MD research project with you all. Yeah, continuing. This is an interventional research project done by myself for the MD in Medical Administration. The initial project is on disaster nursing, and today I will be presenting the relevant areas only. Safe hospital and disaster nursing are two different entities. However, these two can be synergized for a better outcome. In synergy, these two disciplines work together to enhance healthcare system resilience. Because a disaster is a serious disruption of functioning of society, causing widespread human, material, or environmental losses which exceed the ability of the affected people to cope using their own resources, highlights the need of safe hospitals. The term safe hospitals encompasses all health facilities, regardless of their level of complexity. A hospital is safe when it enjoys the highest level of protection possible, when access roads to the health facility are open, and when the water supply and electric power and telecommunications can continue supplying the health facility, thus guaranteeing continuity of operations and the ability to absorb the additional demand for health care. Safe Hospital program consists of four main domains: policy norms and legislation, coordination and service delivery, resources management, knowledge and information management. My study is directly linked with coordination and service delivery as well as resources management. Under coordination and service delivery, mass casualty management system was focused, and under resources management, strengthening the hospital workforce for emergencies and capacity building of medical teams for rapid responses are focused. Those are the ones highlighted in the screen. Let's look into the synergy of safe hospitals and disaster nursing. Considering the continuity of care, safe hospitals ensure uninterrupted healthcare services during disasters. Disaster nursing focuses on effective care delivery during emergencies. In synergy, both aim to save lives and maintain healthcare continuity. Focusing on disaster preparedness and resilience, safe hospitals emphasize risk assessment and disaster-proof infrastructure. Disaster nursing focuses on training for emergency preparedness and response. Both align with global frameworks like the Sendai framework. Moving to systems approach to health in disasters, safe hospitals secure structural, non-structural, and functional elements. Disaster nursing adapts within these systems to deliver patient-centered care. In synergy, integration ensures effective disaster response in secure environments. Further, Safe hospitals train healthcare workers to utilize resilient infrastructure, and disaster nursing develops specialized skills like mass casualty management. In synergy, training in safe hospital protocols enhances nurses' disaster effectiveness. Finally, focusing on community and public health impact, safe hospitals serve as community resilience hubs during disasters. Disaster nursing extends healthcare to affected populations through outreach. Combined efforts strengthen community health systems and reduce the mortality. Going into details, World Health Organization says that disaster nursing refers to the systematic and flexible utilization of knowledge and skills specific to disaster-related nursing aimed at minimizing health hazards and life-threatening damage caused by disasters in collaboration with other specialized fields. These are the principles of disaster nursing. Due to the time constraint, I'm not going to read it out. Disaster nursing is a new and exciting field of study. Researchers are increasingly interested in understanding how nurses can best help people during and after disasters, which helps to improve disaster response efforts. A descriptive survey that carried out in Indonesia demonstrated that the emergency nurses exhibit a moderate level of disaster preparedness, and previous experience with disasters along with participation in disaster training or education shows a significant positive association with the preparedness. Also, findings provide a foundation for designing educational programs aimed at enhancing disaster preparedness among Indonesian emergency nurses. Disaster nursing in Sri Lanka is an emerging field with limited research. A project to strengthen disaster nursing at DGH Mathura was aimed to address the critical gap in understanding disaster nursing in Sri Lanka and contribute to the development of evidence-based practices related to it. The studies was conducted at the District General Hospital Mathura, a significant healthcare facility in the southern coastal region in Sri Lanka. The hospital is located within 50 meters from the Nilwala River and 500 meters from the Indian Ocean. I'm mentioning the location of the hospital because that we are talking about Safe Hospital Initiative, and the location of the hospital is much important in this. Therefore, the institutional vulnerability to floods and tsunamis are high. DGH Mathura is readily accessible to the main commercial town area, and it has to be well prepared to receive mass casualties in any given capacity. Therefore, the healthcare provided by the hospital is crucial to the people in Mathura district. Nursing officers in the hospital plays a major role in the above scenario. Moving to the objectives, the general objectives of the research was to strengthen disaster nursing at DGH Mathura, and the specific objectives were to assess the existing system, to identify the gaps, to develop interventions, to implement interventions, and to assess the effectiveness of the interventions in improving disaster nursing at DGH Mathura. This interventional research project was conducted in 3 phases. Phase 1, pre-intervention phase, phase 2, intervention phase, and the last post-interventional phase. Going to details, phase 1, during the pre-intervention phase, existing system of disaster nursing at DGH Mathura was assessed, and at the end of phase 1, gaps in disaster nursing was identified. This was carried out in 3 separate components. Component 1 was done with observational assessment using 2 observational checklists. Component 2, qualitative assessment by key informant interviews and focus group discussions. The final one, component 3, a descriptive cross-sectional study. Phase 2, intervention phase. By the end of the pre-intervention phase, existing system and the gaps in disaster nursing were identified. With the evidences gathered during the pre-interventional phase, the principal investigator designed interventions to improve disaster nursing at DGH Mathura. The inputs gathered through the qualitative studies as well as quantitative studies and other relevant literature were the basis for the interventions. Sequential meetings were arranged with the relevant stakeholders to finalize the most suitable and feasible and affordable interventions. In the phase 3, post-intervention phase, the effectiveness of the project in strengthening disaster nursing was assessed in DGH Madhura. Additionally, the sustainability of the interventions were carried out. Explaining further, during the pre-intervention phase, I used 5 study instruments. 2 checklists. The first one to get an idea about the disaster preparedness of DGH Matra. The second checklist to assess the CPR practices of nursing officers. A self-administered questionnaire, key informant interview guidelines, focus group discussion guidelines. As I said earlier, the project design was a mixed method that using both qualitative and quantitative. Moving to the details of descriptive study, these are the inclusion and exclusion criteria, and the sample sizes 430 nursing officers, and these are the project stakeholders. The studies tool of the descriptive cross-sectional study was the self-administered questionnaire, which consisted of 9 sections. Moving to the results. Results of the component 1. That is the disaster preparedness of the hospital, disaster management committee, disaster preparedness and response plan, and emergency contact lists were available at the hospital, but those were updated finally in 2019. Disaster cupboard was well equipped and located at the ETU and readily accessible during the mass casualty events. Triage area, resuscitation area, and temporary morgue are identified in the plan, but direction boards were not seen. The communication during disasters were done via public addressing system. Regarding the CPR practices, a scoring system was adapted from a similar study carried out in Ireland. Assessing it, the practices on CPR, 0 marks were awarded for the correct steps, and 5, 10, and 20, like that, penalty marks are awarded for the incorrect steps. So at the end of the study, the minimum mark obtained was 80 and the maximum marks were 160. So none of the participants have performed CPR to a satisfactory level. I have taken only only the major parts of the cross-sectional study. So these are the percentages of the participants that gain good knowledge on disaster management and good knowledge on triage, good attitudes regarding disaster preparedness, and good practices on disaster preparedness. So we can see at the end that they have improved after the intervention. So coming to the third component, this is the qualitative component. These are the positive findings, but I'm going to focus on the negative findings because I made the interventions based on that. So non-availability of a focal point for disaster nursing was the first negative finding I observed. Lack of regular update of the mass casualty incident preparedness plan, lack of conducting regular simulations, non-availability of a consultant emergency physician, lack of well-trained nursing officers on CPR triage, lack of study material on disaster nursing, and lack of medical equipment at the A&E unit of DDH Mathura, and non-availability of a detailed triage tag to be used during the mass casualty incidents. And also lack of easily identification of triage category of the patients in the BHTs was their concern. Lack of easily identification of triage category of the patient by the tag. I mean, for the routine patients who are admitted to the A&E unit, absenteeism of minor staffs, and there were so on. So coming to the intervention phase, based on those findings, finally, I prepared an intervention package named Tomorrow's Safety is Today's Preparation. These are the items or the things that included in the intervention care package, development of a training proposal for the nursing officers on disaster nursing, awareness programs on disaster management, conducting practical sessions for the nursing officers on CPR. Standard operation procedures for mass casualty incident was developed with relevant job cards, introducing a newly designed triage tag for mass casualty incidents, a triage sticker to be pasted on the BHTs for the patients, color wristband for triaging, and new format for the patient belongings handover form. These are the posters which I used. And this is the triage tag, which included comprehensive details. These were prepared with taking the ideas of the relevant specialties. This is the triage wristband, which was designed to be used for the routine admissions, and a sticker to gain the attention and to paste on the BHT during mass casualty incidents. And another main concern of the nursing officers was that they couldn't had a proper patient belongings handover form. They are writing in a book, and there were problems time to time occurred. So I designed a format for the patient belongings handover form. So following the interventional phase, during the post-interventional phase, I use the same self-administered questionnaire and assess the uh, knowledge and practices and attitudes, as well as conducted CPR programs, and then observed how was the practices have improved. So these are the results. And following the CPR practical session, previously it was 0, and during the post-interventional phase, it was 76.7 that who had satisfactory performances. So in conclusion, inadequate level of knowledge on disaster management, triage, and CPR practices among the nursing officers at DGH Mathura was identified. These are my recommendations, that SOPs for disaster nursing should be developed at the national level, and series of awareness programs, capacity building programs to conducted for the nursing officers to improve the competencies associated with disaster nursing. Adequate encouragement, of course, it's the motivation. And newly designed IEC material should be reassessed and annually by an expert panel, and new materials should be designed accordingly. Regular practical sessions should be arranged for the nursing officers on CPR and triage especially. At that time, there was no consultant emergency physician, but now there is. So these are my recommendations, and this is the commendation letter I received from the director of the DGH Mathura. And the sustainability of the project was ensured by participatory approach. That the focal point for disaster nursing was identified, and group of liaison nurses were identified from each unit. And WhatsApp group was formed to ensure the communication among them, and guidance through the SOPs, dissemination of the findings of the project with relevant stakeholders, and continuous supply of the triage tags, wristbands, stickers by the Hospital Development Committee, and also training sessions were included in the annual training calendar. These are my references. And once again, I would like to pay my sincere thanks to the College of Medical Administrators of Sri Lanka, my project supervisor, Dr. Srinika Valyanga, CCP, Dr. Sarath Samarge, Senior Fellow, IHP, Dr. HDB Herat, Registrar, SLMC, all staff at DGH Mathura. Finally, Dr. Suranga Dolamulla, Director, Laboratory Services, giving the opportunity this time. Thank you.
Thank you very much, Samita. It's really a good initiative. I think you have done a lot of things in terms of the disaster preparedness and management of the nursing staff, and I think it's you have made a synergy between say, hospital and disaster nursing. So Once again, I need to read YouTube audience. You can type your questions at the comment section, so we can answer. You can take up your questions at the Q&A session. So this is today's session is Safe Hospital Initiative organized by College of Medical Administrators of Sri Lanka. We have got 3 eminent speakers, and they have made 3 presentations and 4 presentations. That's Dr. Samin Samarapon presentation being done by me. So 4 presentations have already been conducted. So it's time for Q&A session. So may I hand over the Q&A session to Dr. Kumar Wickramasinghe, President CMASL. He's the expert panelist, and I think he can get the lead of the Q&A session. It's over to you, sir. So, Doctor, your mic is muted. All right. Until Dr. Wickramasinghe is available, he's there, but his mic is mute. So I think we need to contact him.
Sorry. Yes, I followed up all the presentations.
We can't hear you.
Can you hear now?
No, we can't hear you.
We can hear you. We can hear you.
Okay. I think majority can hear me, Suranga.
No, still we can't. I think there's an issue with the mic.
Can you hear me now?
Still, I think somebody.
Can you? Suranga,
We can
you hear me?
you.
Can others hear me?
Yes, we can hear you.
Okay.
I'm Dr. Herath.
I can see Dr. Herath. Thank you very much for your presentation, and all other speakers that have done a great job. Of course, I can't see the audience because they are on the YouTube. I believe that sizable number of people have joined the thing because it's a very interesting and very important topic. And I believe that medical administrators who face problems, safe hospital in day and every day, so they might have a lot of queries, questions that they might need to correct their views and also to get some updated on. Shall I invite and again thanking all the speakers and Dr. Suranga Doramulla for organizing the this webinar. We can open the floor for questions. If everybody can see, listen, can hear us, please start pour your questions so that we can discuss the matter with the resource and then by the panel also. Thank you.
So may I ask a question?
Please.
It's really important for the medical administrators. The question is, how can hospital administrators effectively integrate safe hospital principles into routine maintenance and staff training program? So the question again, how can hospital administrators effectively integrate safe hospital principles or initiative into routine maintenance and staff training program? I think I would like to ask this question from Dr. Herath if it's available over there.
Yes, thank you, Suranga. I think as in my presentation, I have put there was a slide where the role of the medical administrator, where the activities were divided into 2 components. One is preparedness, and other one is the response. But we will, for the moment, leave aside the response. But preparedness. I believe that, I always try to emphasize the fact that preparedness is a continuous activity that need to be carried out throughout the year. That means, firstly, it is part of our normal development activities of the hospital and the maintenance activity. So therefore, first thing is, in my slide, I am trying to get into that one, but yeah, until such time, I was telling that I need to tell that the risk assessment is the first part, where you need to make sure that risk is assessed continuously until you come to a conclusion where these are the risks posed by the hospital. And then what is the capacity, or what we call is vulnerabilities? What are the weaknesses in our setup? Those two things are once measured, we can see what are what are our capabilities to handle it. So these three aspects, if we measure at one point, you will see that there are certain dangers, and then there are certain vulnerability. That means the risk, or the probability of getting affected, and then these are our strengths. And then always we can see that there is a gap. So that gap need to be continuously filled. So therefore, we know that as I preparedness and response planning software part, infrastructure development and human resource training part are the main three important aspects that need to be carried out throughout the year. That is why I always say that disaster preparedness unit or cell in a hospital is something that has worked throughout the year. Some people might say that without a disaster, what is the use of maintain? But we don't need a disaster management unit as such, but in a planning unit or a quality unit or somewhere, we can maintain this cell to continuously prompt the administrators that these are the dangers, these are our probabilities to getting affected, and these are the things that we can do to improve it. I think I tried to do summarize it and give it so everybody can understand and keep in their mind what would be the how this can be included into our normal routine development and maintenance activities. Thank you.
There's a one more question. It's from the YouTube channel, where it's from Dr. Rajikran Javardhan. How can we compare our hospital against the other hospital in terms of the different components of the safe hospital? So once again, the question is from Dr. Rajikran Javardhan. How can we compare our hospital against the other hospital in terms of the different components of the safe hospital? It's over to you. I think Dr. Come on here. I think he's going to answer the question.
Yeah, actually, with the safe hospital checklist, we can assess all the hospitals, but we have to use the same checklist, same modules. Module-wise, we can analyze, or else we can analyze for the total index. By calculating safe hospital index, we can compare with that categories, category A, category B, category C, like. With that, we can compare contrast to what extent aspects wise, structural, non-structural, functional, and also overall wise. To what extent this hospital is safe. In that case, we have to address with long-term interventions or short-term interventions according to category.
So that is from our any more questions. We have got another like 8 minutes. Chaturika, do you have any questions? I think we need to check our YouTube channel as well. Let me go through the YouTube channel and see whether any comments over there. think we have really mentioned this particular thing, but there's a question. What are the key steps for healthcare facility to develop and test comprehensive emergency response plan in line with the WHO Safe Hospital guidelines? I think Dr. Herath has answered the question, but they're asking in a different manner. What are the key steps?
Yes.
That
Yes,
means I think you have
yes.
answered in terms of the preparation of the establish of the committees and all. So anything else you want to add? So that's they want to test as well.
No, that's right. Yeah, the testing is the one that they, because we can test the our capacity in two occasions. One is in real-time disasters. Other one is the before the disaster. So once you try to test it at the time of a disaster, if you fail, everything is fail. So therefore, before the disaster, we need to test our capacity. That is what we call the disaster drill or disaster simulation, you name it. And these simulations can be desktop simulations or real-time simulations. And I know our Sanita and all these others, the National Hospital, I know that even before this so-called major incidents that took place into this, what do you call this, Easter attack time, 1 month before that, the National Hospital had conducted a drill to see whether they are capable of doing it. And those good practices has helped us to see whether we are functioning the way that we want it. So the best way is to do the drills as frequently as possible. I always say you cannot have, I mean, it's not practical to have once in 6 months, but probably drill in once a year is not impossible, because we conduct spirit ceremonies once a year. We conduct the Dane or Christmas carols, Bhakti Gita, all these things once a year, Aurudu Utsava. So why can't we do a drill once a year? And most of our people are happily taken that up. And so that's what we have to do. Thank you.
There's another question to Dr. Kumar Vikramasinghe. I think he is the key personnel who's managing the largest hospital in Sri Lanka. So your disaster preparedness plan, where you get a lot of the disaster in terms of the other disasters also indirectly affect your institution as well in terms of the number of patients and the other things. So do you have you got any sort of a disaster initiative, disaster preparedness plan with aligned with the WHO?
Sorry,
WHO?
Suranga. Please, I didn't hear the question because I got disconnected for a while. If you want to ask me any question, you have to repeat that.
Yes, sir. This is regarding the Safe Hospital Initiative and Disaster Preparedness Plan. So I just want to ask from you are running the largest health institution in Sri Lanka. So making the disaster preparedness plan which align with the Safe Hospital Initiative to a large hospital is not that easy. So do you have any idea how can you have any sort of initiative have started in terms of preparation of your disaster preparedness plan into the Safe Hospital Initiative?
Yeah, thank you very much for asking the question. The disaster management plan for the National Hospital has been there for probably a long time, because we are the people who faced most of the disasters in our history, from the Civil War and after that bomb blast, many other things. So it's like this now, the present plan being updated. We get a new knowledge, new updated, as you said, the maybe WHO disaster management plan and been updated. And I'm happy about the present plan in the hospital. And as Dr. Herath just mentioned, that is time tested. Now, if you can recall, go back to the Easter bomb incident. and we are the people who got the maximum number of people during very, very short time, because generally it takes time for the people to come, but in very short duration, we got about 300 people and some bodies also brought into the National Hospital. But by knowing the plan, which was basically communicated to us through the Disaster Management National Center, we were ready, and now all our people who are in the list waiting for assess the disaster was alerted. So they came on time, and evacuation done. So this all done with the plan. The plan is not stagnant. It has been updated, and also, as already mentioned, we are doing rehearsals every 6 months at least. So that is how it goes. So it's like, so I think we have a lot of guidelines how to do, and disaster management division in the ministry and WHO has given a lot of guidelines how to manage how to prepare a disaster plan. But I still believe there are specific things to each institution as per the availability of specialties and also availability of resources. So that is the way to do it. And of course, we are always there. We can share our plan and give any updates, and we training even if the need comes in. By the way, we are doing it even now, and I have a specialist here in front of me who's a anesthetist and the intensivist, where we are always doing these updates and things. And I want also to use some few words about this training needs. There's a question about whether how the training could be updated. I think training need assessment is a part and parcel of job of a medical administrator. So they need to do it every year and to identify what are the needs in their staff, and then also not by asking but assessing the things. Probably Dr. Chaturika presented about the knowledge of nursing, also about the CPR, and so these things should be always assessed and identified as a priority. And other thing is about this maintenance of the structure. I think again, administrator should know what's happening around, and there must be a team of people who will assess the things and we have to prepare a yearly plan for repairs, minor repairs, and everything that is there. So I think that has to be done in more comprehensive way, so that you can identify the places and structures you might need the major innovations, maybe minor innovations, and also dangerous for the to keep. That's what I think. Thank you.
Thank you very much, sir. I think we have got only a couple of minutes, so that's one question for Dr. Chaturika. It's really, she has done a research on disaster nursing, and it's in par with Safe Hospital Initiative. And you have done a lot of intervention, and this is very successful. And the question is, how are you going to take this the good initiative to the other institutions, since I have seen that some initiatives really work. So how are you going to adapt this initiative, the similar kind of hospitals in Sri Lanka?
Thank you, sir. I hope to share my findings with DPRD, and I hope that practicing this in the other institutions should be coordinated by a national body. So once I share it, they will do more research on it and adapt it accordingly. Thank you.
I think it's really a good thing. I think you need to really share your experience in the national level. So for which I think you have tapped the correct pathway. So we are looking forward to take it at the national level and implement the relevant type of hospital. Thank you very much. So I think our time is over. I think we have done Nadia on time. So do you have any other questions? Yes. And there's one question from our end as well.
So this, we are having disaster management committees. We have addressed to much extent regarding function aspects. We have way forward with structural and non-structural aspects rather than the functional aspect. Because to some extent we have developed that. That is something multidisciplinary. So if there's a way forward with that, we can much develop this initiative.
I think it's a comment from it's a comment rather than a question. I think it's the type of way forward. Dr. Hera, do you have any other things to discuss?
Yes, as probably in your presentation, you mentioned about the involvement of the Moratuwa University regarding the structural assessment and other things. So it's I mean, there are multiple organizations, agencies who are very keen to support this Sri Lankan health system as far as this structural or any other integrities. We always harness the capacity or the resources from the software part or the planning structural, not structural, but non-structural, and the functional part, as Prabhat pointed out. Structural part, we are still there are many more that we can do. So we need to get their support, like the engineering, probably Sri Lanka Institute of Engineers, Sri Lanka, or the universities, like then the IT organizations, how we can use the information technology to coordinate all these activities and to see the vulnerabilities or the risks assessed in a scientific way, because we doctors may not be the best people to do the risk assessment in certain aspects. So therefore, if we can get them, that will be a very, very productive and fruitful area where the multiple or the multitude of professions are involved to make sure that whatever the risks are early identified, and solutions are also. Sometimes we identify the solution, but we don't know we identify the risk, but we don't know the solution, and we might have to get an expert of that different field to get it. So if we can get everything together very easily, we should be able to get these things fixed before leading those deficiencies into a disaster. Thank you.
Yeah, thank you very much. I think it's really a timely need. We need to understand, we need to identify the relevant stakeholders. So if I really, the particular thing what you have been discussing is really to engage with the other institution like the Moratuwa University. We have done with the Minister of Health. Yes, I think, can you go to the next slide, please? It's a pilot project and it was really successful. So I think with that strength, I think we can incorporate with many other agencies as well. So the next slide, please. Yeah, that is the one. That is the one. Yeah, it explained before that. Yes. Department of Civil Engineering, University of Moratuwa, with the support of the DPRD, conduct a set of pilot studies to evaluate the perception of safe hospital for Sri Lanka and the applicability of the health sector initiative Sri Lankan context. That's a really good study, pilot study. I think we have really discussed some funding of those studies as well. So with that said, I think we need to really wind up this session, since it's a really we have taken really more than 1.5 hours, and this has been transmitted into the YouTube. I have seen 30-40 YouTube viewers were there time to time, and there were some questions and comments also. There were some comments from our colleagues regarding they have really appreciated the particular webinar, and I think this will be available online. We are going to do a bit of a editing thereafter available online. This can be useful for even for the postgraduate trainees in not only medical administration, even postgraduate training in disaster management. Not even it's limited to the they need to have idea about safe hospital initiative. That therefore this particular. So with that background, may I invite President CMSL to participate in this event as a panelist as well as the guide in this event. Secondly, all the presenters, including Dr. Herat, Sanita, and Deputy Director MRI, and as well as Dr. Samin Samarakon has prepared her presentation. And thirdly, our IT team, including Dr. Richie and the IT specialist. Even though they are medical professions, they are really good in synchronizing Zoom into YouTube. That's really a good thing. And same time, the academic committee of College of Medical Administrators, they have done a lot of things in terms of the managing, the navigating this the pre-webinar event. So we have already done the 3 webinars for CMSL webinar series. The first one is for the pharmaceutical, second one for the laboratory, third one is today's one is for the disaster management. So we are hoping to conduct a few webinar series in this year if possible. So that's from my end. So thank you very much for participating and giving you all the inputs and presentations, as well as all the YouTube viewers for your valuable times and your the comments and questions. So once again, appreciating all your support, let me wind up this session. Thank you very much and have a great day. Thank you.